Hi, good morning everybody, and welcome to the EAN 2026. I am really excited to greet you today morning for the first session of this year's Congress. So thank you for joining us. We will now talk about the neurological phase of menopause. And recently, a few months ago, we have conducted a survey of European neurologists asking whether they consider female-specific factors in their daily neurological practice. And in this survey, and I would like to thank to everybody who completed it, in this survey, 60% of European neurologists stated that they do not feel educated enough to address female-specific. Is it working? Yeah, this one is working. Okay, thank you. So yes, 60% of European neurologists said that they do not feel educated enough to address female-specific features in their daily practice. So with this session today, we hope to change this. The first speaker is Anna. Anna Sevchak-Josefchak is a neurologist at the University of Lublin in Poland and also holds a PhD in neuropathic pain. Here in the EAN, Anna is chairing a scientific panel on pain. So thank you, Anna, for joining us today, and please go on. I'm looking forward to your talk.
Good morning, everyone. Of course, first of all, Katarina, thank you for this kind introduction and for your invitation.
Thank you so much, Anna. This was really interesting, and I think it's very important, as you said, that this misperception that once menopause started, migraine just disappears. So we shouldn't think that is true anymore. Thank you. Are there any questions for Anna? Yeah, please.
Thank you. Very interesting talk. I'm not a headache specialist. What would be your advice with regards to ladies in the perimenopause phase asking for HRT treatment to help with their migraine? Thank you.
Yeah, thank you for this question. So I think that Diana will also talk about this topic, but first of all, I think that we shouldn't think about the use of estrogen therapy in these patients. Yeah. So perhaps we should look for the other way, yeah, of administration or other substance type, that estrogen, yeah, because perhaps it will increase the risk of other disorders than only migraine.
I won't go specifically into the topic of migraine concerning hormonal replacement therapy, but indeed we know that for oral contraceptives, estrogen is not recommended, for example, in migraine with aura. And yeah, so there may be an increased risk, I guess, also with the hormonal replacement therapy. I don't know if you are aware of any study with migraine and aura and hormonal replacement therapy.
So we are afraid of the use of estrogen hormone replacement therapy also in young patients. So, for example, we know that the risk of cardiovascular events in patients with migraine with aura, who is, for example, smoking, yeah, and is taking estrogen hormonal replacement therapy, are also higher. So contraceptives, yeah, with estrogen. So those numbers are higher. So I think it's still the same thing in menopausal females. Yeah.
And I think this is really a good point. That was a really, really important question, because we see there are such questions coming up in the practice. And I think we neurologists should try maybe to have more contacts with gynecologists and maybe to make those decisions jointly with them, because the views may not be the same on both sides, which then brings patients in a difficult situation when they get different informations from their neurologist or from the gynecologist. So I think we really do need more dialogue with gynecologists there.
Yeah, I will stay with this comment of Katarina, because when I'm treated patients with headaches, yeah, and we have a woman who is in transition in menopause, yeah, and she's coming to me. So I saw her 1 year ago, and she was fine because she was taking like preventive medication, for example, for migraine, yeah. And then she said like, oh, I feel totally good. I don't have attacks, like migraine attacks, yeah. And then I see her for the next time, yeah. And she said like, okay, I'm feeling worse because I have much more attacks. I don't know what is going on, yeah. And then I'm starting to speak with her, yeah, about what was going on, if something changed. She said that like, I started to have symptoms of menopause. So I spoke with my gynecologist, and he or she gave me HRT, yeah, for menopause. And then I found out, okay, but there is estrogen inside, yeah. So because of this estrogen, because you had, for example, migraine with aura, you will have much higher level or much higher numbers of attacks. So due to this treatment. So I totally agree with Katarina that we should have better contact with gynecologists about this topic. Yeah.
Any other questions? Yes, please.
I am a gynecologist.
Thank you so much for joining us.
Just share with you what we do. So I work in Switzerland, and in our guidelines, migraine is not a contraindication for the hormonal therapy, but we prefer in that case the transdermal way. But both migraine with and without aura, they are not a contraindication in our guidelines. Just to let you know.
Okay, so thank you for this comment, because it's also important for us, yeah, to know which guidelines you have as a gynecologist, yeah, because we are not using the same guidelines, yeah. So perhaps it's important to have this dialogue between neurologists and gynecologists, yeah, to have the same point, yeah. Thank you.
And it's really great to have a gynecologist in a room here in neurology session. Thank you for joining us. Okay, any other questions for regarding migraine in postmenopausal women, or any comments? Does anybody want to share their experience? Okay, then I will just ask Anna one very short question, and this is relating to CGRP levels in postmenopausal women. Is there any data? How are the levels? Are they increased or decreased? And are you aware whether they could have any association with vasomotor symptoms?
Mm-hmm. Yeah, thank you for this question. So about CGRP levels, peripherally, yeah, we have still inconclusive data, because we have, like this year, a study from Denmark was published in Neurology, for example, and in this study, authors said that the levels of CGRP in plasma are lower in migraine patients, in migraineurs, in compared to healthy population. Yeah, but for example, when I was preparing my presentation, yeah, I found out the information that CGRP levels are higher in menopausal women. So I think we still need to have a bigger population, yeah, to to be sure what is going on with CGRP level in plasma. Nevertheless, we think that due to decreased level of estrogens, the level of CGRP will increase in plasma. And what I found out also is that decreased level of estrogen and also higher level of CGRP are also connected with vasomotor symptoms in migraine patients. Yeah.
That's really interesting. Thank you. And that was kind of a good introduction in our next topic, which is stroke and menopause. And I have a big pleasure to introduce Diana Aguiar de Souza, who is a consultant neurologist and a neurology professor at the Lisbon Central University Hospital and the Lisbon School of Medicine. And Diana also has an important role as a co-chair of the guideline production for the European Stroke Organization. So thank you so much for being here, Diana, and we are really glad to have you today. Thank you.
Thank you very much for the kind invitation and for the kind introduction. So we will now talk about menopause and stroke, and indeed some of the topics will be connected also with the previous talk. So starting with the case, so we can imagine, a 46-year-old woman coming with a transient episode of speech disturbance, 15 minutes, so sounds very much like a possible TIA, complete recovery. She has some vascular risk factors, so she has hypertension, she has high LDL cholesterol, and indeed, if we go back to her personal history, it is indeed relevant that we know that she had a bilateral oophorectomy at the age of 40, so quite early, followed by severe vasomotor symptoms. So why is this relevant? So how should we use this information together with, of course, all the, etiological workup and so on for the possible TIA, but how should we integrate this kind of information in the secondary stroke prevention? So we already heard some of the definitions. These are other definitions that has to do, and it is relevant for the stroke risk. That's why we are discussing this. Also the definitions concerning the age. So menopause is defined as the loss of ovarian follicular activity and therefore a reduction in the estrogen production. It usually goes between 45 and 56 years of age, but 90% of the women will be on this around this age, as we heard, 51 years. But there's, a large part of the population still that will have premature menopause. And this will be defined as onset before 40 years of age, and then early menopause if it is before 45 years of age. And this can be due to different causes, and this will be also relevant, which can be spontaneous, like a primary ovarian insufficiency, but also can be surgical or medication-induced, for example, breast cancer and things like that. So surgical menopause is the result of this surgery, like this patient we were hearing, and this very early menopause before 45 years of age will happen in around 5% of women, both surgical or spontaneous. So it is a large number of people, as you imagine. So what are the stroke rates around this age? So there are a lot of studies assessing this. Of course, there's a lot of variation as well. It has to do with, risk factors in the population, the time where the study was conducted, and so on. But you see that women in this period between 45 and 54 years of age, in most of the studies will have a lower stroke risk compared with men. And that has a lot to do with the impression many physicians have that women have a lower risk of stroke. This comes from the fertile period. But actually, in the next 10 years after this period, so after midlife, let's say, these sex differences will decrease or even reverse. And actually, the stroke rates, of course, also increase for men during this period, but will double for women in this period of 55 to 64 years compared with 45 to 54 years. So why is this? So there are also quite a lot of studies already trying to assess this change in cardiovascular risk factors. We see here two good examples from this review. If you compare the first year after menopause and then the first to the fifth year after menopause, we see that there's quite a lot of changes. In this first study, increased systolic blood pressure, pulse pressure, increased LDL-C cholesterol, increased triglycerides, fasting glucose, BMI. And in other studies, especially the lipids have stood out as one of the major changes happening in this period. So these are changes that more or less are consistent across studies. So overall, we see that there's the decline in estradiol levels. This leads to changes in the lipid profile. This leads to changes also on the blood pressure. And indeed, this also may be related with endothelial function changes. And still, data are lacking on whether hormonal replacement therapy will modify this risk, and we'll go into this topic later. So this is a summary of some of the more pathophysiological changes that may happen during this period. Of course, there may be also other risk factors like lifestyle risk factors, physical inactivity, sarcopenia, increased weight, obesity. But in terms of the mechanistic view, there are direct effects on the renin-angiotensin system, with increased angiotensin 2 and increased endothelin 1 and decreased nitric oxide synthase. And this will lead to increased oxidative stress, vascular wall inflammation, endothelial dysfunction. And there are also, as we discussed, in this indirect effects on lipids and also insulin resistance and inflammation. So overall, this may lead to increased atherosclerosis and increased rates of ischemic heart disease and stroke. So why should we care about this? Because indeed, both has a secondary prevention and also has a primary prevention. These sex-specific risk factors have been highlighted, in guidelines and then several studies as relevant. And indeed, menopause is an important factor coming into this. It is a major endocrine metabolic vascular transition, and especially in women with earlier menopause, there has been an increased risk of stroke, and therefore this is something we should, take care of and ask people about. So some of the most relevant evidence, the most early evidence about this increased risk with early menopause comes from this very important study, the Framingham Heart Study. And you see here a comparison of the risk of stroke in different periods of age. So if menopause comes before 42, between 42 and 54, and more than 50 after 55 years. And you see there's quite a big difference in terms of the Kaplan-Meier curves for the events in terms of stroke according to this period for the age at menopause. So this was one of the early studies suggesting this, and it has been indeed confirmed in other studies, although sometimes with some inconsistency across cohorts. And what about surgical menopause? So of course this is a different situation because it is not spontaneous, it is induced by the surgery, and actually there's good evidence that the risk is even higher in these patients. So we should pay more attention to these patients. You see that for each, in this large study with more than 200,000 postmenopausal women from pulling together individual patient data from several observational studies, we can see that for each 1 year decrease in the age of menopause, there's an increased risk of incident cardiovascular disease of 3% in the natural menopause and 5% in the surgical menopause. So there's this suggestion of an increased risk, and even if we look only to stroke, it is the same, and concerning the HRT therapy, we will go into that later. What about vasomotor symptoms? You know, vasomotor symptoms are related with vessels, so is it relevant? Indeed, we see that there's a suggestion in this meta-analysis for increased risk of events, cardiovascular disease events in general, for women with vasomotor symptoms, and there may be, you know, explanations for this, but we also know that there may be some bias because women with severe vasomotor symptoms also tend to be older, to have higher BMI, to have a more unfavorable social economic status, and also other risk factors for cardiovascular disease. But indeed, there's this suggestion that these people are especially prone to have cardiovascular increased risk. And there's also data going into the reproductive lifespan, so maybe also the period where the fertile age is active, so coming from the beginning of the fertile age to the end of the fertile age, if it is less than 30 years, this has been identified as a risk factor for stroke as well. But there's less data on that specific metric. One of the theories concerning the effect of hormonal replacement treatments in this patient, so coming to the topic of hormonal replacement treatment, is that the effects of this estrogen, if patients have early atherosclerosis, may be beneficial. So there may be increased vasodilation, reduced inflammatory activation, reduced lesion progression, but if there's already established atherosclerosis, then the effects are mostly harmful. And this may be one of the, you know, more mechanistic explanations for the difference in terms of the risk of hormonal replacement therapy in different types of patients. However, overall, studies have shown that hormonal replacement therapy has a less favorable profile concerning the risk of stroke. So there's still some doubt about the early cardiovascular risk. But concerning stroke, it is very consistent in, you know, different meta-analyses. This is the Cochrane meta-analysis from 2015, but there are other studies I will show as well, that there's this increased risk of stroke from hormonal replacement therapy overall in primary and secondary prevention in this analysis. This is a more recent meta-analysis, and again, you can see the effects on different symptoms. So indeed, you know, genitourinary system, the symptoms, the functioning assessment, and so on. There may be some benefits, but it is very consistent that concerning cerebrovascular disease, stroke, non-fatal stroke, there's an increased arm of hormonal replacement therapy. And even if we look to this comparison for early hormonal replacement therapy and later replacement therapy, although we do see a trend towards maybe a point estimate that is a little more favorable for early hormonal replacement therapy, still we don't see an effect of a protection from hormonal replacement therapy in any age group, at least a significant one, and indeed, especially in the older groups, we do see quite an increased risk of stroke. So this hypothesis that early treatment is maybe a little better, although still for stroke we don't have an evidence for benefit, and then that with, you know, as patients get older, there's really a definite increased risk of stroke from hormonal replacement therapy. This is more or less a consensus. We have mentioned this before, and our colleague from gynecology mentioned very appropriately this important question. There's still not so much data, so it's mostly observational data. So we do need trials assessing this in more detail. But there's this observational data here from, for example, from a French database, very large cohort of patients. And indeed, for transdermal estrogen hormonal replacement therapy, it seems to be safer, and maybe with a better profile also concerning the risk of stroke. And the same here from the UK cohort, again observational data, and we can see that this transdermal treatment seems not to increase the risk of stroke, but again, we do need higher quality data for this question. So what do the guidelines say, at least the stroke guidelines? So from the American Heart Association, we have this relatively recent guideline for primary prevention, and indeed it goes into this topic, and there's this definition of premature ovarian failure and early onset menopause, and that patients going through this should be screened, and the vascular risk factors should be managed to reduce the stroke risk. And for the specific recommendations, we can see besides this one, they should be informed, they should be assessed for the risk factors, there should be this is even a recommendation that there should be modification of the vascular risk factors to reduce the risk. But then in women, at least in women with more than 60 years of age, meaning more than 10 years after menopause, there is an excess risk of stroke, and this should be really very well weighted against the clinical benefits. So there's a risk for harm in these patients. What about hormonal replacement therapies? So this is a very nice flow chart. So if patients have contraindications, and of course patients with history of breast cancer, liver disease, myocardial infarction, of course estrogen-dependent neoplasms, deep vein thrombosis. So of course for vein thrombosis this is absolutely contraindicated. And then if the patient has not any of these contraindications, there may be a consideration with better data for transdermal formulations, and a risk for increased stroke that has to be considered for the oral formulations. What about the ESO guidelines? They are from 2022 for stroke in women in general, and there's a chapter on menopause as well. And for hormonal replacement therapy, these studies were considered, and you see here from the 6 randomized clinical trials that hormonal replacement therapy did not reduce the risk of stroke, so should not be used for that. And there's even a trend towards harm. And again, the same for fatal stroke, so even severe stroke, it is the same. So this is again the recommendation, although it is weak, and there's low quality evidence that in women we suggest against the use of hormonal replacement therapy to reduce the risk of stroke, to reduce the risk of hemorrhagic stroke as well, and also mortality. So these women should be informed, especially the ones with premature menopause. There should be questions also about vasomotor symptoms. We do need more data on this. We should do the cardiovascular assessment, lipid screening, diabetes screening, and we know from the gynecology guidelines that there's some recommendation for very early menopause to do some treatment until the age of natural menopause. But of course, with patients with increased risk of stroke, this has to be considered as well, because there's no evidence that this is reducing the risk of stroke. And indeed, we should consider the contraindications and the possibility also for the transdermal estrogen, although we do need more data. And this decision has to be always individualized for the specific patient. There are some information from the American Heart Association on for patients, and this may be useful as well. And it goes also into other symptoms and other questions patients may have. And also it makes some recommendations for lifestyle modification, which is always good. As I said, we do have knowledge gaps, so we do need more data on these different routes of treatment, on the cardiovascular management, on the age at menarche as well, and the lower doses also should be studied for this impact. So coming to our patient, what should we do? Of course, the standard management, but also this risk-enhancing control about the long-term assessment and a closer look into the prevention strategies. And indeed, hormonal replacement therapy should not be used for stroke prevention, but this should be taken in account in the patient history, and we should remember about the early menopause as a risk factor for stroke. So thank you very much, and greetings from Lisbon.
Thank you so much, Diana, for this excellent overview of the potential benefits and risks of hormonal therapy in postmenopausal women. Are there any questions for Diana? Any questions regarding stroke and menopause? or any thoughts, any comments? Okay, so I would like to ask you, you already mentioned on several points that we do have differences between different preparations, because what seems to be a bit of a problem that we see like hormonal therapy as one entity when there's so many different options exist. And I think you mentioned that the transdermal preparations have better evidence profiles. Do you know any information about focal, about topical, vaginal estrogens? Would you recommend your patients with high stroke risk to take some vaginal estrogen preparations?
Yeah, that's mentioned on the American guidelines already for the primary stroke prevention, and indeed there's no evidence of increased risk of stroke with topical preparations. So that's which means vaginal estrogen. So that's indeed something to be considered for these patients. So there's no evidence of increased risk. Of course, data is still relatively scarce, but that's reassuring that at least we can consider these treatments in these high-risk patients. Then for transdermal preparations, as I said, there's observational evidence. And indeed, they seem to be a better option. May have to do with the hepatic effect of the oral administration of estrogen. So, of course, more research into this topic will be useful, and definitely that's a gap in stroke and women medicine. Research that we do need more evidence on this, because that will be very helpful, I think, for many patients to know that they could have this type of treatment.
Thank you. Yes, please.
For gynecologists, the local, so vaginal estrogen, are not considered as a hormonal replacement therapy at all. So they are just considered as a local therapy for vaginal dryness, or so it does not belong to the hormonal replacement therapy, just the oral or the transdermal. So as we see from our side.
Okay, thank you. That's very important.
It's no problem to use a local estrogen vaginal in any condition.
So they don't have any systemic effects?
No.
Okay, that's great to know. Thank you.
Not demonstrated.
Thank you. Any other comments? Yes, please.
Can you also say something to progesterone? What is the role of this, and to the relative elevated testosterone in the menopause compared to estrogen, and progesterone compared to the premenopausal situation?
Yeah, indeed, there's good evidence of a change in the lipid profile, and that's well known. The HDL goes down and the LDL goes up. And there are several, endocrine reasons for that. But overall, I think there's not, very detailed recommendations on what to do, But overall, I think we should assess the risk factor of the specific person in total. So going through all the risk factors and doing an assessment for the risk of cardiovascular disease and cerebrovascular disease. And then if the risk is higher, considering all these factors, then we should be more aggressive in terms of primary prevention. And of course, for secondary prevention, there are established levels already for LDL, after stroke or after myocardial infarction in patients with high-risk atherosclerosis or not. So we can use that information, but I guess we can add these additional risk factors to have that in account as well, especially for early menopausal women, because we know these changes will happen early, and so the risk may be higher in the long term. So definitely it's not something that is well accounted for in the guidelines or in the panels for risk prevention, but it's something we should consider in the individual decisions, and probably have better data in the future on these specific risk factors as well.
Thank you. Would you suggest monitoring of triglyceride levels in postmenopausal women or perimenopausal women?
I think so. That's part of the, the lipid panel. There's not, so the data for the association between risk of stroke and these levels is not so good. So the association is less important. But still, it is something that should be considered. And of course, if there are very high levels, that should be treated anyway. So that should be, I think, part of the assessments. Although then the evidence that reducing will reduce the stroke risk is not as strong as for, of course, cholesterol.
Thank you. Any other questions or comments? No? Okay, then I think we can move on to the last topic, which is Parkinson and menopause. So our last topic is on menopause and Parkinson's disease. And in a survey that we recently conducted, this survey of EAN members, and again, thank you for everybody who participated, 40% of European neurologists stated that they think that female hormonal factors do not impact Parkinson's disease at all, or if they do, then only very slightly. And I would like to use this opportunity to prove those people wrong. Yes, so in the next 20 minutes, I would like to talk with you about several points. So first of all, menopause and Parkinson, do we need to talk about this? Is this relevant? Then we already heard about the role of estrogen in migraine, in cardiovascular diseases, and does it also have a role in Parkinson's? Then is there any link between menopause, different types of menopause, and risk of Parkinson's disease? In Parkinson's disease itself, are there any specific features that we need to be aware of in our women patients? And then at the end, again, which role may hormonal therapy play for women with Parkinson's disease? So to start, is it actually important? Well, this question is quite easy to answer. Yes, it is really important to think about links between menopause and Parkinson's disease. And this is because we know Parkinson is a disease that is very fast growing in its prevalence. It is the fastest growing neurodegenerative disease. And based on the global burden of disease data, we expect that 2050 there will be 25 million people worldwide living with Parkinson's disease. And for the same reason, because we as population are aging, we women spend more and more time in a postmenopausal phase. So at the moment, an average woman in Europe spends 40% of their life in postmenopause. And women, as we know, make up 51% of the world's population. So taken together, we have a disease that is frequent and is even becoming more and more prevalent, and we have this long period of our lives. So it's important to understand how the two interact. And why do we think that they might interact? Well, we have many signals to think this. We know from the epidemiological studies that Parkinson is more prevalent in men than in women. We know that the age of onset of Parkinson's disease is later in women than in men. Once the Parkinson develops, then Also, it is typically different in men compared to women. So, for example, in terms of motor symptoms, women tend to present with tremor more frequently, whereas male patients usually present with more bradykinesia, hypomimia, speech issues, so also more axial symptoms. Non-motor symptoms differ between the sexes as well. So women have more pain, experience more anxiety and depression, whereas men tend to progress faster into a cognitive decline. From the neuroimaging studies, we also have some evidence that the neurodegeneration rates are greater and faster in men, and also we women metabolize levodopa, which is the main pillar of Parkinson's treatment, differently. So we do have higher concentration of levodopa in plasma. So all in all, it seems that there seems to be some protective factors in us women against Parkinson's disease. And likely there are several, because there are many biological differences between male and female individuals, not only hormonal, but also, for example, genetic. However, estrogen here seems to have an important role. And we have already heard that estrogen is really a brain hormone, we can say. It's a neuroactive steroid, and it does influence the dopaminergic neurotransmission in our brain. So we do know from preclinical models, we do know from the studies in animals that estrogen enhances synthesis and release of dopamine, while at the same time reducing its reuptake and breakdown, and also modulates the dopamine receptor sensitivity. And that's why during our reproductive phase, our dopamine in our striatum actually fluctuates in accordance with the fluctuations in estrogen levels in plasma. So it seems to really, it seems that estrogen really plays an important role in dopaminergic neurotransmission. And it seems that we women are, our bodies and our brains are used to it, and we notice it when we lose this factor. So several studies have signaled that women with Parkinson have a shorter reproductive lifespan, meaning a shorter exposure to the natural endogenous estrogen than women who don't have Parkinson. And this association seems to be even more pronounced when this estrogen drop happens abruptly, which is the case after a bilateral oophorectomy or hysterectomy, for example. This is a recently published meta-analysis that has shown that women with bilateral oophorectomy have a heightened risk of Parkinson's disease. And I think this is really a nice opportunity, because for Parkinson we now have more and more potentially disease-modifying trials, which all need to be started as early in the disease as possible. So if we are aware of vulnerability of this population, maybe we all together can be more sensibilized, and maybe we have a chance to recognize Parkinson's disease earlier in these women and offer them possibly participation in disease-modifying trials. But this is in future. We are not that far yet. Yes, so when Parkinson's disease develops already, there are also certain aspects that differ, aspects of care that differ for our men and women patients. And this is one very nice overview by Professor Powe that shows different phases of Parkinson's disease. And on this picture of Professor Powe, I added these small ladies on all phases of Parkinson's disease where it is relevant to consider sex and gender factors. And you can see that basically throughout Parkinson's disease, it is actually important which sex and gender is our patient. And it starts already in the prodromal phase. So prodromal phase of Parkinson's disease is a phase before the motor symptoms occur. And people present with a range of different non-motor issues that are quite unspecific. So they might present with some memory issues, with some emotional distress, or constipation, or increased tiredness, or maybe disturbed sleep. And those might sound familiar to you because those symptoms are very similar to symptoms of peri or menopause. And that causes a problem that in women it may be hard to recognize that these symptoms are beyond menopause, that those are caused by a neurological disease. And in many cases, it's not rare that this leads to a delayed diagnosis of Parkinson's disease in women. And this is an interesting study that has shown that women actually seeked medical attention with the same delay after their first symptoms started. But for women, it took much longer to get referred to movement disorder specialists than for men, because those symptoms were in many cases not recognized. Then once Parkinson's disease started, motor symptoms are present, and we are in a dialogue with our patients, which therapy should we start. And as it is usual in medicine, we have several options. None of those is perfect. Each one has pluses and minuses that we need to discuss with our patients and take this decision together. Also here, sex and gender are very relevant. Because among the options that we have, for example, the number one choice is levodopa, which is the most effective treatment for Parkinson's disease and has the greatest effect on the motor symptoms. However, in a long term, levodopa is associated with occurrence of motor fluctuations and levodopa-induced dyskinesia. And these are much more frequent in women than in men. On the other hand, the other alternative option, dopamine agonists, may be associated with different neuropsychiatric features. Among those, impulse control disorder, and men have a significantly higher risk of those problems than we women. So also in this conversation, when starting the first therapy, we need to bring in those sex and gender aspects. And then as the Parkinson progresses, people start experiencing those already mentioned motor fluctuations, which express themselves as different effect of the medication and loss of the medication effect between the doses, as well as levodopa-induced dyskinesia, which are involuntary movements. And I think this is, in my opinion, the most important study in Parkinson's disease, in gender factors in Parkinson's disease. This is a recently published observational study that has followed people with Parkinson from the diagnosis throughout starting levodopa and then for 2 years. And in those 2 years, you can see here the comparison comparison. In terms of the matter fluctuations, 50% of men developed matter fluctuations during these 2 years, but 65% of women. And for the dyskinesia, it was even more obvious, this difference. So 2 years after starting levodopa, 5% of men, but 15% of women had levodopa-induced dyskinesia, so 3 times that much. And then, however, we do have treatments that we can offer to people who have matter complications and levodopa-induced dyskinesia. So we offer those people device-aided therapies, which can again bring a balance, which can shorten this period of either fluctuations or dyskinesia. And now you would think that women, because they fluctuate more, they get more of those treatments, but actually the opposite is true. So we know for the deep brain stimulation that women actually get disproportionately less referrals and less surgeries, although when they undergo the DBS surgery, they have same benefit as men do. We don't have any data for the pump therapies yet, but we know here from the analysis from Kasia Smilovska and Vanessa Carvalho and others that these female-related features are not that considered in trials for pump therapies, because either women participate less or when they do, the reproductive history is usually not recorded. And then we came to the advanced Parkinson's disease, to the late stage of Parkinson's disease, where the disease changes and axial symptoms, gait issues, and falls become the most severe problem. And also here, women seem to be more vulnerable, because you know that osteoporosis is more frequent in women than in men. In people with Parkinson, it seems this difference seems to be even more pronounced. So women with Parkinson really have a very high risk of osteoporosis. And this has consequences, because if you combine osteoporosis with falls, it can lead to fractures that then restrict mobility and lead to worse outcomes. And this is exactly what has recently been shown now in the PPMI Parkinson Progression Markers Initiative analysis, that women with Parkinson have more fall-related injuries and more fall-related hospitalization than male patients. And then finally, since estrogen seems to have so important role in Parkinson's disease, naturally there comes a question: can we then give women with Parkinson a substitution? Will that be helpful? And the answer is that we do not know. And I think today you heard so many we don't knows, because it's actually surprisingly little research being done in the role of hormones for neurological health. And this is an example. You can see here we have here in the EAN we have just conducted a systematic review on the role of hormonal therapies for postmenopausal women with Parkinson. And overall we found only 5 studies that have investigated these questions. And you can see from their date that they are quite old, some even from the 90s. And then they used the different preparations from those that we use today. So we really cannot take those results for our clinical practice. And the studies were also small and were methodologically not that robust. So the answer is that we really don't know, and it's a huge knowledge gap that we really need to investigate, because it can be a good opportunity to improve the management of Parkinson's disease in women. With that, so if you are interested in the topics that we talked about today, I would like to invite you to join the Insight Network. So since 2024, the American Academy of Neurology has a women's neurology curriculum which seeks to answer all these questions. And the Women's Neurology Insight Network is a US-based online network from neurologists who are working towards the improvement of neurological care for women. And you can look at different offers here. There are always series of free webinars, really nice educational opportunities. And with that, I would like to thank all of you. I hope now people would answer this question about from our survey differently, that not 40% of people would say hormones are not related to Parkinson. We now know they are, pretty much so. And with that, I would like to thank the team here at the EAN that is working really hard to address those issues and to improve our knowledge. And I would now like to hear from you, your thoughts or questions or comments.
Yes, I have a question regarding the DBS in women, because I heard previously that the reason that women are undergo DBS less frequently is that it is often a wake surgery and that women are more hesitant towards that ID. Is it also something you heard, or are there other relevant factors why they don't get DBS?
Yes, thank you very much. That's an important question. Again, I have to give you one I don't know, because these are only epidemiological data, so reasons have not been explored, but we will do it with the time. But I think you made a really, really important point, and this is something I don't know from the literature, but I do know from my clinical practice that this is like you are saying, because we think deep brain stimulation, we can do it in wake patients, and we are very proud that we are doing it, and we announce it like a great thing. But then women usually are terrified when they hear that somebody is going to open their skull, operate their brain, and they are experiencing with a full consciousness. So I think that's really, really important point. We need to tell them it doesn't have to be that way. So it's also possible with anesthesia. That's possible. And this is a good point that when somebody is hesitant, we need to understand why are they hesitant, what are their reasons, because we can avoid them. Possibly. And my colleague, Heidemarie Zack, who is working in Wien and is a hypnosis expert, she, for example, she went to the surgery with her patient and has done a hypnosis for her female patient, and that was very successful.
Thank you very much.
Thank you also.
Hi.
Hi.
Sorry, thank you. That was a great talk. I was just wondering, I know there's limited research, and you mentioned about the estrogen therapy that changes the pharmacokinetics of levodopa. Would you, in your day-to-day practice, use estrogen-based therapy in somebody with levodopa-induced dyskinesias, or would you tend to avoid based on that?
Thank you. Just to repeat, just to be sure that I got your question right. So you are asking if somebody with levodopa-induced dyskinesia, if we would use device-aided therapies?
No. Would you tend to avoid their recommended estrogen-based HRT if they've already experienced a dyskinesia? Would you tend to avoid increasing estrogen levels then?
If I would tend to avoid to give estrogen to somebody who has dyskinesia,
Yeah.
That's your question. Okay, Thank you. That's a very important question, and I think that's a kind of a barrier, because I think there is a lot of suggestions that estrogen increases dopamine levels. Again, these are only data from the animal studies, but what it seems to be doing is not increasing but modulating, so taking care that the levels are more or less equal during the day. So actually it has a positive effect. theoretically it should have positive effect. And one of those 5 studies that I shown, a very small study, but it has shown that dyskinesia was improved with hormonal therapy with estrogen. Yeah, so it seems to kind of normalize this abnormal metabolism. Thank you. Yes, please.
A question in the back.
Thank you. We've had 3 wonderful talks, and in many ways the talks have exposed the deficiencies of a young male neurologist. And following on from your last slide, the initiative taken by the AAN, do you think the EAN and other professional neurological bodies need to lobby hard for dedicated neurogynecologists? We've got neurourologists, a neurogynecologist.
Thank you. I think it's a beautiful idea. Yes, I think that would be really, really helpful. And we did learn from the American Academy of Neurology, and we are working tightly with the leadership there, with Professor Esther Bui, to also offer more education for neurologists here in Europe. And this session is a part of it. So it's really nice that all of you are here, because it shows that this is something that you also recognize as a gap and want to improve. So yes, thank you. Any other questions?
May I ask a question? Sorry, I'm... Okay. So thank you for the really excellent overview. I think it goes beyond Parkinson's and really highlights the, sex differences in this disease in particular. So going to your slides on the delay on the diagnosis, that's really interesting. Do you think that the menopausal symptoms may account for that? Because the age for early, for many patients with Parkinson's, and the early symptoms will be around that period. So do you think that non-recognition of the early Parkinson disease symptoms may be related with this menopausal attribution of the complaints?
Yes, for sure. Thank you, Diana. That's an important point. I think there are probably many factors that are leading to this, probably not a single one, but I think, as you are saying, this overlap with menopausal symptoms for sure has a big role in the fact that just this alarm doesn't go by doctors when women present with these unspecific symptoms. I think it's really important factor, yeah.
Yeah, but we cannot forget about depression also, mask of depressions. Yeah, because we can see depression also in Parkinson's disease, during migraine disorders. Yeah, so it could also masking, the beginning of the disorder.
Yeah. Okay, do we have any other questions? Doesn't seem to be the case. Then again, thank you everybody for coming, joining us so early on Saturday. Yes, and watch this space. We are doing a lot in EAN to improve care for women with neurological disorders. And thank you for supporting us with that.